Okay, so can you see my slide?
Yes.
Yeah.
Okay, thank you. So today I would like to talk about the roadmap to organize colorectal cancer screening in Asia. So this is the content, the agenda of my today's talk. First of all, I would like to talk about the screen modality because I know that some of the countries in Asia now are going to start the population screening program, or some of the countries would like to change from stool-based screening test to endoscopy-based screening. And secondly, I would like to talk about the young onset colorectal cancer.
Yeah. Slide is freezed.
Oh, okay. Okay.
Not yet, I think.
So can you hear me now?
Yeah, yes.
Okay, so may I go ahead or?
I think your slide never move.
Oh, really?
Yeah.
Okay. So now I'm in the first slide. Can you see the slide?
Yeah, but
it's still.
yeah, it's still okay. Now it's share from our side. Okay, we can share for you now.
Okay.
Okay, so may I control or you control?
We can.
It's a control in the meeting room.
Oh, okay. So so restart the talk from the beginning. Okay. So today I would like to talk about the roadmap of colorectal cancer screening in Asia, and this is especially important because currently we are facing the COVID-19 pandemic, and many countries are now also facing a decline in cancer screening rates. So please move on to the next slide. So this is the agenda of my today's talk. First of all, I would like to talk about the screening modality because there are many countries in Asia that would like to start cancer screening program. And also in some countries, there is the action of changing from stool-based test to endoscopy-based screening. And secondly, I would like to talk about the young onset colorectal cancer. And nextly, I would like to talk about the awareness issue and what is the bottleneck of the currently available screening program in Asia. And finally, I would like to mention about precision screening, whether it is feasible. Next. Okay, so what is the optimal screening test in Asian country? Next. So colorectal cancer incidence is much higher in country or region with higher level of economic development in terms of human development index. Next. Okay, sorry. Okay, so this may be my old slide. Okay, please move back to previous slide. 不好意思，古梅，你放的是11月10号还是11月11号的 slide？
Just wait a minute. Yeah.
Sorry, maybe this is not the most updated slide.
Never mind. Yeah, just wait. Yeah.
11.
Come on, you just wait. Okay. Yeah.
Okay.
The slide we show is from November 10th.
No, I have a new one. November 11. Okay, maybe I will try from my side again.
Yeah, please.
Okay. Okay.
Yes.
So I'm now moving the slide. It just goes smoothly or?
Yeah.
Okay. So this is the correct one. Okay. So in those countries with high HDI level, organized screening covering the entire population of screening age is recommended. But in countries with middle HDI level, opportunistic screening can be provided to those who are at higher risk or more willing to undergo screening. So in countries with low HDI level, awareness of the symptoms pertaining to colorectal cancer is more important, and the treatment for symptomatic colorectal cancer is a more practical approach compared with the mass screening given the constrained healthcare resources. So in this slide, you can see from the population demographic point of view, we can see that the aging population is increasing in Asia, but the working age population is declining. So such a trend is expected to worsen in the upcoming decades. Expanding aging population represents an increase in the public spending, including healthcare expenditures. So we can see the strong contrast between those economically developed countries in Asia and in the US, and this will definitely affect the way of providing cancer screening services. Whether colonoscopy could be a viable option as the primary screening exam is largely affected by the size of the target screening population and the capacity and the manpower of colonoscopy, taking into account the demand for surveillance colonoscopy. And in most of the Asian countries, healthcare services are provided by the government with the so-called single-payer system. So even considering the relatively low cost of colonoscopy in many Asian countries, offering colonoscopy screening is still too costly and labor-intensive. Moreover, the expanding aging population is another hurdle of offering colonoscopy-based screening. So we can see the population age 54 to 72 years old. Exactly the screening age has doubled in the past 2 decades in Taiwan. So this is the population pyramid. The screening target population is comprised of those aged 45 to 80 years old, and the main healthcare manpower and the funding source for screening are provided by those aged 20 to 65. If we look at the population pyramid of this country 40 years later, the young population still comprise remarkable proportion of the entire population. And we can see that this country has abundant, stable resources over time and can afford more labor-intensive way of screening, such as direct colonoscopy screening. And this is United States of America. However, if we look at the population pyramid of some Asian countries, we can see a large aging or aged population in relation to the young age group. That means a smaller proportion of people have to provide both manpower and the funding source of screening for a much larger proportion of people. Such a situation will worsen in the upcoming decades, and the selective screening is probably the more practical and the favorite way of providing screening services. And in such kind of countries, selective screening like FIT screening is a more reasonable and a preferred choice for population-based screening setting. The demand for colonoscopy is rather steady if only screening colonoscopy or diagnostic colonoscopy after positive stool test is taken into account, given stable population size, screening uptake, and the positivity rate of stool tests. However, if surveillance colonoscopy is further taken into consideration, the demand will be much higher and increase along with the expanding aging population. So if we use colonoscopy screening, such demand for surveillance exam would be much larger than by FIT screening and the impact largely on the already overstretched colonoscopy service. And the public preference is another important concern. According to previous randomized control trial in the US, the preference of screening tests was very different among different ethnic groups. In the Asian population, stool-based test was the preferred test compared with direct colonoscopy, which was a strong contrast with that in the white population, in which nearly equal proportion of the people choose colonoscopy and the fecal occult test. The reason why we use FIT as the primary screening modality is that it can specifically select people at higher risk of colorectal cancer from the large population, thereby reducing the demand of colonoscopy. This is supported by the observation in our program. The odds of having advanced adenoma and colorectal cancer were 4-fold and nearly 20-fold respectively compared with the general population. So the effectiveness of FIT screening has also been demonstrated in the organized screening program. The overall effectiveness in reducing colorectal cancer mortality was 35%, and advanced stage colorectal cancer was 29% after adjusting for possible selection bias and the changing epidemiology. If we compare with the effectiveness of colonoscopy-based screening, which reduced colorectal cancer deaths by 53 and 56%, according to the study from the US, the currently observed effectiveness in FIT screening program is acceptable if the number of colonoscopy that performed is taken into account. And in addition to the expanding aging population, increasing young onset colorectal cancer is another important issue to be dealt with in Asia. It is evident that young onset colorectal cancer is not only an emerging clinical and public health issue in the Western country, but also in Asia. Previous study from the Asia Pacific region revealed that there was a remarkable increase in rectal cancer in the male gender. The reason of increasing incidence of early onset colorectal cancer are poorly understood. Difference in clinical presentation and the tumor phenotype raise the question of whether early onset colorectal cancer is a distinct disease with different mechanisms of pathogenesis. Although family history and the hereditary cancer syndrome account for some cases of early onset colorectal cancer, lifestyle and the environmental factors are also likely to contribute. Increasing incidence have occurred more rapidly than that can be accounted for by change in the population genetics. A recent study showed that the rate of germline mutation in young onset colorectal cancer is higher than that in the old onset colorectal cancer, and such findings justify universal genetic testing for all diagnosed colorectal cancer cases, which may help to identify the prevalent cases. Germline testing with multi-gene cancer panel should also be considered for all young patients with colorectal cancer. So it is obvious that in the screening program, at least in Asia, this high-risk population is underserved. In such context, starting colorectal cancer screening for young population should be considered, and at least from those with family history of colorectal cancer. The presence and the number of first or second degree relatives with colorectal cancer are positively associated with the risk of colorectal cancer. So therefore, starting screening from such a subpopulation is the low-hanging fruit for colorectal cancer screening in the young population. And nextly, we would like to think about the awareness issues. Insufficient awareness toward colorectal cancer, even in high prevalent countries, is another concern in Asia. Here show the probability of encountering different kinds of accidents in our daily life. The likelihood of suffering from colorectal cancer in a lifetime is, however, much higher than those accidents, but many people pay only little or no attention to it and would rather to purchase an aviation personal accident insurance rather than go for colorectal cancer screening. Without high screening participation, we cannot expect high level of detection of colorectal cancer or any significant neoplasm, even using the most sensitive screening test. Here is an example. In this Spanish study comparing FIT with colonoscopy, FIT had 10% higher participation rate than direct colonoscopy. Though the detection rate for non-cancerous lesions were higher in the colonoscopy arm, there was no difference in detecting colorectal cancer based on the intention to screen analysis, which highlight in pivotal role of public participation. And the previous survey study in the Asia Pacific country had revealed that knowledge about colorectal cancer or screening, family history of colorectal cancer, doctor's recommendation, and the age older than 50 were the positive factor that motivate people to go for screening. Among them, physician's recommendation was the most important, and it is the responsibility of all physicians rather than GI doctor that should advocate colorectal cancer screening. And the low colonoscopy rate after positive FIT, another important concern in Asian countries. From our data, it was demonstrated that those who were not compliant to colonoscopy after positive FIT was associated with 64% increase in colorectal cancer deaths. Therefore, physicians should also emphasize the importance of undergoing colonoscopy after a positive FIT. And what are the bottlenecks of currently existing program? Here are the currently existing population colorectal cancer screening program in the Asia Pacific, and all the program use FIT as the primary screening modality with 1 or 2 year interval. In the analysis of Taiwan program, however, we observe a discrepancy in the effectiveness in reducing colorectal cancer deaths or advanced stage cancer from proximal and the distal colon. The discrepancy in effectiveness on proximal and the distal colorectal cancer may be caused by insufficient sensitivity of FIT for proximal lesion, inadequate colonoscopy quality, and some others. It is also possible that the biology of proximal neoplasm is distinct from distal one. Therefore, we may consider to lower the positive cutoff of FIT, shorten the inter-screening interval, use 2 stool samples for FIT screening, or apply other screening tests. The possible explanation of the lower sensitivity of FIT for proximal lesion include the decreased amount of blood along with the bowel movement from proximal colon. The bleeding from non-cancerous lesion is only intermittent, and the smaller amount of blood from the selected lesion. The risk of PCCRC, the post-colonoscopy colorectal cancer, was associated with both adenoma detection rate and the fecal intubation rate, 2 of the most important colonoscopy quality metrics according to the results from Taiwanese program. And you can see that ADR was inversely associated with the risk of interval type post-colonoscopy colorectal cancer, which was in common with that observed in other Western studies. Interval cancer is a challenging problem to be dealt with. And our recent analysis revealed that FIT interval cancer comprises the majority of all interval cancers and are more advanced in stage, largely affecting the effectiveness of the screening program. So our colleagues have already showed this framework of colonoscopy quality auditing system in Taiwan. And currently the hospital in Taiwan are asked to upload the colonoscopy finding to the central database of the government using the standardized reporting format. And in cooperation with the professional society, the screening organizer regularly audit the colonoscopy quality by calculating the key quality metrics like ADR and the fecal intubation rate, and then feedback to the individual endoscopy unit. So we have already demonstrated this curve, and along with the improvement in adenoma detection rate and the fecal intubation rate, we can see a declining rate of PCCRC. And nextly, I would like to talk about the precision screening. So a gender-adjusted FIT cutoff could also help to maximize the detection of important lesions like colorectal cancer or advanced adenoma. And most importantly, it does not put in further workload on the already overstretched endoscopy service. And our previous study had demonstrated that the likelihood of detecting colorectal cancer or advanced adenoma at colonoscopy increased with fecal hemoglobin concentration. And therefore, it could be used as a tool of risk stratification to set the priority to manage the backlog of diagnostic colonoscopy in the FIT screening program during the recovery phase of COVID pandemic after the long pause of screening services in Asia. And this slide shows the estimated number of colorectal cancer being undiagnosed in those who were positive for FIT but have yet underwent colonoscopy this year in Taiwanese program. And this was caused by a 3-month pause of screening service due to a large-scale community outbreak in northern Taiwan during this May and August. And based on the positive predictive value parameter from data in 2020, we estimated that in those who had fecal hemoglobin concentration higher than 100 microgram hemoglobin per gram of stool, there are still 480 missing colorectal cancer, which is more than that, adding up the total number of missed colorectal cancer in lower 3 tier of fecal hemoglobin concentration. So we can use this to deal with the backlog of colonoscopy. Of those who were not compliant to colonoscopy after positive FIT, fecal hemoglobin concentration is positively associated with the risk of colorectal cancer death. Therefore, we can intensify the referral of colonoscopy, for example, by repeated contact with phone call for those who have higher level of fecal hemoglobin concentration. And the risk of PCCRC was also positively associated with baseline fecal hemoglobin concentration, and we may use this to tailor subsequent screening or surveillance strategy. And even under the positive cutoff, fecal hemoglobin concentration is positively associated with the future risk of developing advanced neoplasm. And the state-of-the-art AI technology can facilitate colorectal cancer screening. In addition to enhancing the performance of colonoscopy, AI could also help to diagnose pathology slide in a high throughput manner, automatically generate endoscopy report, identifying potential target population based on interval, individual risk profile, and notify them to go for screening. The automatically generated colonoscopy quality metric can further apply to the so-called pay-for-performance health care system. And all these approaches may collectively contribute to both the effectiveness and the efficiency of colorectal cancer screening. And it is also the right time for us to embrace AI technology to assist our screening services. So ladies and gentlemen, this is the summary of my today's presentation. Don't forget that a screening population is dynamic in terms of its size and the demography. And we have to balance between screening effectiveness and the available manpower and the funding resources. And the young onset colorectal cancer is an emerging issue, and there are still several bottlenecks to overcome to optimize the effectiveness of FIT screening. And precision screening based on fecal hemoglobin concentration is the successful first step to achieve precision medicine in colorectal cancer screening. And this is also the right time to apply cutting-edge technology like artificial intelligence in colorectal cancer screening. And for more detail, we are very happy to inform you that you are very welcome to refer to our recently published handbook on colorectal cancer screening. And in the final chapter, we have more detailed information on the future and the roadmap of colorectal cancer screening. And thank you very much for your kind attention.